Hi. First, RECIP criteria, it's a composite criteria based on two main parameters, volume changing and occurrence of new lesion. So those parameters were already evaluated and validated on PSMA PET CT, and we missed the part of SPECT CT for our clinical practice because SPECT CT is widely available and cost-effective in the world, and we can have this image after each cycle of lutetium PSMA. So the aim and the motivation for this study was to assess this RECIP criteria with SPECT CT because SPECT CT is widely available and we have it after every cycle. And basically, we miss some criteria for SPECT CT for reading it after lutetium PSMA. So that was the main goal of the study. As I said, we validate the RECIP criteria on PET. And for PET, we already demonstrated that we can use either a quantitative tumor segmentation software to get the volume changing, or we can do it visually. With SPECT, for now, we don't have any quantitative tumor segmentation software. So we decided to do it visually to make it immediately available for clinical practice. So the result of the study will just allow us to believe in the result of the SPECT CT, especially volume changing and occurrence of new lesion, to be able to predict overall survival based on volume changing and occurrence of new lesion. For the first time, we demonstrated that the data of SPECT CT after 2 cycles of lutetium PSMA with volume changing and occurrence of new lesion are prognostic of overall survival. This is the main result of the study. And then we compare it to PET, and we just show that SPECT CT had a lower prognostic accuracy than PET. But if we add PSA with a composite criteria using SPECT CT and PSA, we are able to restore and to decrease the difference between RECIP 1.0 on PET and RECIP 1.0 on SPECT CT. Mostly not. The study allowed us to identify, and it was predictable, that with SPECT CT, fewer patients were classified as prognostic disease, and mostly because the ability of SPECT CT, due to its spatial resolution and sensitivity, did not detect all new lesions that will be detected by PET. So we were aware before the study that this limitation, this technical limitation, will occur with SPECT CT, but the main question was not to answer the technical issue or difference between SPECT and PET, but it was to assess if with this kind of technology we can stratify and we can assess patient response with lutetium PSMA, and we can do it without decreasing the performance of the treatment. This study is the first step. It's the first step because it's a retrospective study, multi-center, and so it's a first step to see if RECIP 1.0 can be generalized on SPECT CT. We had other limitations. There is no direct comparison with conventional imaging, CT or bone scan, because it's complicated to do all this type of exam to the follow-up of the patient due to clinical workflow, and obviously for the quality of life of the patient. There is other limitation. Our study was performed on classical Hanger camera, so we cannot apply directly this result on new advanced digital SPECT system, which could be better than the result that we got. And then The other limitation is we had only 73 patients with both PET and SPECT. We will need more patients to make this result more stronger. This study first demonstrated that we can apply standardized criteria that were used in PET to SPECT. So the increasing number of patients treated with lutetium PSMA conjugate with the availability of SPECT-CT after each cycle forced us to just find a way to assess patients with the image we have easily in clinical practice. And especially, we have the cost effectiveness of SPECT versus PET and the quality of life of the patient. That means the patient can have the answer just the day or even the same day on the treatment of lutetium PSMA, and it doesn't need to come back 2 or 3 weeks later just to do a PSMA PET. So this kind of data are important to just move forward to use SPECT-CT and to push the development and the research on the SPECT-CT scan after every cycle of lutetium PSMA. But these results are for prostate cancer, mCRPC after lutetium PSMA, but we can imagine that this is the first step for using this kind of parameter for other diseases that would be treated with radioligand therapy in the future. What I can say is RECIP criteria is really simple criteria. It's based off volume changing and occurrence of new lesion. And even without being a nuclear medicine physician, you can understand easily that if your disease is increasing in volume or if you have new lesion, your prognostic will be lower than if you have not a progression of the volume or no occurrence of new lesion. So all we are doing here is just using simple criteria to be able to improve the patient classification after 2 cycles, and to be able to even change the treatment. And this is not for now, it will be in the future, but to change the treatment as quick as we can when we know that the treatment is not effective. And this is the real aim of developing standardized criteria to assess patients after treatment.